red box is our fracture episodes, and they are much higher cost than our non-fracture. So we are trying to create pathways specific for this population to see if there's anything we can do on the post-acute side to kind of move them through the system. So this is something we are currently tracking to see what happens. And so with spine, we did end up withdrawing from spine. And the reason why is because of clinical practice changes that the methodology, the target price methodology, didn't account for. So we implemented care redesign similar to joint. We were sending a lot to facility-based post-acute care, and we had a lot of readmissions. We knew we could reduce those. But our index admission payments were trending much higher than our baseline. We were receiving outlier payments from Medicare for kind of more complex patients that we were seeing within our spine population. So speaking with our kind of neurosurgeons, orthosurgeons, it seemed to be a kind of a cultural clinical practice shift from doing just a 2 to 3 level fusion to doing a 4 to 8 level fusion to kind of recreate the curvature of the spine, which used more hardware, increased our charges, and resulted in an outlier payment from Medicare. So because of that, we lost in spine, basically had to pay that outlier payment back. So this is just kind of a visual representation on the financials of what happened. So that gray within the red box is kind of our Q1 2014 performance within one DRG in spine, and that gray is all the outlier payments for that hospitalization. So compared to our baseline, which is the second bar, it's about $6,000 on average higher than our baseline index payments. And so for cardiac valve, this is also something we're trying to keep track of because we did have a lot of opportunity with our inpatient rehab again, which we were able to reduce. However, on the index payment, again, we're seeing a lot of outlier payments, which, so far, the national trend factor seems to be keeping up with. However, as things, as we do more TAVR procedures, which are getting into their own DRGs, we do have a physician who's only doing TAVRs to stabilize patients for even more major surgeries. So this is something we don't know if the methodology will really address or keep up with. So if it doesn't, we may have to, decide what to do about cardiac valve as well. But for now, we're kind of just keeping track of our data, seeing how things go, and kind of assessing our risk versus our opportunity. So for medical bundle, I just wanted to kind of touch on why we decided not to do these. I guess our NYU leadership really wanted to do something around chronic care, patient management, using a bundle type of model. However, when we spoke to our clinicians, they didn't really understand the whole DRG structure for, say, a heart failure patient. Someone comes in with heart failure to the hospital, they're going to treat them as heart failure, and their question was, why would this patient not fall into this DRG? Because we did see, over kind of half of our heart failure diagnosed patients fell into some other DRG because they came in for something else that kind of bumped them up to that DRG. So to our clinicians, it just didn't make sense. I'm not going to just focus on something that I think will hit this DRG. I'm going to just focus on the patient as their symptoms, kind of progress. So that was our first issue. We also didn't really understand the whole triggering a bundle based on inpatient for these types of patients. We felt that we really should be preventing that hospitalization. Starting in an ambulatory space is really where we think we can have more of an impact. And then in the 90 days, we just felt that this should be more of a kind of a longer time period of risk that we would take on for these kinds of patients. If hopefully for our next step, I did want to show this as kind of our patient population. So this is CHF patients, but the bubbles are kind of all their comorbidities, and the size of the bubble is how many patients have, those conditions. When we looked at pneumonia DRGs, we found very similar distribution. When we looked at sepsis, similar distribution. So basically, these patients are all very similar. So as our next step, as we go forward, we're hoping for something that kind of makes more sense to our clinicians to group these patients more appropriately in a way that, they can better kind of understand the payment model as well when they're managing these patients. And, this this is kind of what we're hoping to get to is more of a, as we move into more widespread population management, kind of how can we better take on these chronic condition patients, because that's where we think really the next kind of wave of opportunity is. And I'll hand it back over to Jess.
Thanks, Lily. So AAMC has a small group of hospitals that have been live since the last quarter of 2013 or at some point in 2014. And then we have a much larger group that entered the risk phase for the first time in 2015. And I'm going to share some lessons from both of those groups. On the screen, you can see 7 hospitals' quarterly financial results grouped by episode type. Now, this is only 7 hospitals for 3 or 4 reconciliations, so it's certainly a small sample, and we can't deduce large generalizations from this data yet. But what you see very clearly is that some of the highest source of savings are in major joints. And indeed, for 2015, our hospitals have been running at major joints. This has been our most popular episode. And that's for a few of the reasons that Lily discussed. Hospitals tend to have a decent volume in major joints. It's very easy to create a process map for this episode and identify areas where you can pursue further efficiencies. And then there's a pretty clear post-acute care strategy of, when clinically appropriate, shifting patients from IP rehab to SNF or home health. But when you look at some of our medical conditions, you can see that hospitals are breaking even or sustaining a loss. And indeed, hospitals have been much more hesitant to go live with these episodes in 2015. And that's for a few reasons. For one, as you all know, chronic condition patients tend to be much more complex. Average episode payments are highly variable across time, and we're seeing those patients being readmitted across the entire 90-day episode. So here's the graph that John showed you earlier, comparing the distribution of payments across time. And you see that red continuing from days 0 post-discharge all the way to 90 for CHF. And our hospitals have pursued one of 3 risk mitigation strategies to deal with this. So we have one that decided, I really can't do anything about readmits post 30 days at this point. I'm just going to do a 30-day episode. We have others who are live with a 90-day episode, and they're those ones who are kind of breaking even. And they've realized, my care managers are actually really only consistently following patients 2 weeks out. We need to change that. We're going to hold on to a 90-day episode for a while and see if we can elongate the time that those community health workers and care managers are tracking those patients. And then, of course, you could just not go live or drop the episode. And as NYU said, they think that CHF and other medical conditions may more appropriately belong in a payment model like ACOs, where we're ultimately trying to actually prevent any hospitalizations from occurring, period. So we also saw some risks that were posed by what John calls the game. As you know, a target price is based on a hospital's own historical data trended forward by a national trend factor. And you saw with NYU what happened with spine. So what happens when a hospital's own growth drastically outpaces that of the national trend factor due to changes in care redesign? Well, when we got our target prices in November 2014 for our hospitals looking to go live in 2015 and compared what their payments were in the baseline to essentially just the end of 2013, we saw huge growth. This is one hospital's DRG episode growth for the 3 DRGs that make up CHF. And you're seeing that just from the period of 2009 to 2012 to the end of 2013, their average episode payments grew by 15 to 45%. And so, of course, we're like, what could possibly be causing this? So we looked into their claims data. Now, for context, the target prices for CHF are probably 20, 30,000 something. And we saw that they were using this drug milrinone at a much higher utilization rate than the baseline. You can see that it costs $60,000 for one usage in some instances. And we asked the docs, is this appropriate? What does milrinone do? And they said, milrinone increases the heart's contractility and reduces pulmonary vascular resistance, aka it treats CHF. So they felt that this was appropriate usage for the patients they'd been receiving at this time, and ultimately decided they couldn't overcome that hurdle and they just couldn't go live with CHF, even though they'd been kind of strongly considering it in the past. Now, the trend factor and target price methodology can also pose issues for the highly efficient provider. And this is a common theme that I've heard throughout this conference. So what do you do when you're nationally renowned at producing great outcomes for a certain condition and your volume is tremendous? That's what we see with this hospital here. This is their 90-day major joint average episode payments from baseline to now. They're highly efficient, and that's evidenced by the fact that across from 2009 to 2014, their average episode payments are varying by at most $1,000. They have a very low coefficient variations, which is another measure of how variable your payments are. They went live with this episode. They're essentially breaking even. And they're one of the best performers at joint replacements in the country, and their financial savings are less than 0.5% of their target amount. So this becomes especially important when we think about a rebasing methodology, and that's something that the AAMC is paying attention to as we comment on potential expansions of this program. So the data doesn't provide the entire risk opportunity profile for a hospital. We noticed that these were some barriers to success that we saw for hospitals who were sustaining losses or having trouble getting enough engagement. So the one thing is essentially not spending enough time doing your homework, understanding what the data tells you and how your target prices are derived and how they're going to change. So we had one hospital that was a new hospital and didn't have a baseline. So the state average was used to calculate their target price. The problem was they treated really complex patients. They're in a certain kind of low-income area, and they tanked the first quarter because that state average was not an accurate representation of their own costs. Then, of course, another common trend I've been hearing throughout the conference, having an internal physician champion. So a clinician who can really garner organizational buy-in and help move an initiative forward. And then another issue we saw was actually hospitals that were too risk averse and didn't take enough time to understand certain program design features that could help them. So, doing major joints and picking the most conservative risk track C, and then cutting off your opportunity for savings. So as of July 2015, these are the episodes that AAMC convened group hospitals will be live with. But we're definitely eagerly looking at October 2015, the last time you can add episodes. And we've been thinking through some kind of creative risk mitigation strategies to address a lot of the points that John and Lily have been bringing up. So, when an episode has low volume, it's way too variable, or there's not sufficient opportunity to reclaim that 2% discount and then generate savings. So what we've been thinking about is encouraging hospitals to go live with clinically similar episodes simultaneously. And you can see here, the far right column shows what different important measures are when you combine all these episodes. So you can see volume's much higher, variation is lower, the opportunity to reap savings is much higher. And you can see that visually here. So the green line is the combined average episode payment across time for the 5 episodes below it. You can see it's much flatter, much less variable. So that produces a greater deal of certainty and less risk. And these are some of the pairings that we've been exploring. We already have one hospital that's committed to doing CHF and cardiac valve for July. And then we're also, having cautious conversations with brave souls looking at sepsis and UTI. So we're very hopeful that, a year from now when we come back, we'll have some more interesting results to share from the potential bundling of these clinically similar conditions. So that's all I have. I think we might have 5 minutes for questions.
Hi there, my question is for John. How did you decide decide 100 to be the threshold for minimum number of episodes? It seems low.
In some cases it was arbitrary. I think if we'd gone much higher, we would have knocked out too many episodes, especially in some of the smaller hospitals. If we'd gone much lower, we would have started getting the pogo stick effect of too much variation where you really couldn't nail things down. But I guess the best answer I can give, which isn't a great answer, is it seemed like the right number.
My question's for Lily. On the joint replacement, going from the inpatient rehab to home health, did you look at any outcomes data with respect to return to function days or anything on the outcome side to say there was no change in quality or was it better or worse?
So far we've only looked, readmissions has been our major kind of, outcome indicator that we've looked at, because the data for the functional status, we haven't found anything very reliable for that yet. So in terms of the readmission, we actually saw a decline from, in our baseline we were around 12% readmission rate over the 90 days, and we went down to about 8%. And we looked at kind of where those readmissions were coming from. A lot of them are from the SNF, frankly. So from the home health, we saw very little that we were concerned about. And just talking to the patients, we do some patient experience surveys. They're happy in the home. So nothing concerning has come up as a red flag for us.
First of all, I want to thank you for that wonderful presentation. The game and the vision, with the way you broke it down, that is exactly the way things work. And I work with Evacor, and specifically, we look at this and the experience with being in over 20 bundles for one particular organization. I guess this is sort of more of a comment, and maybe there's a question in there, but we can look at this and we can game the game, potentially. The rules are there. If all this BPCI was just meant towards joint replacements, what then? Well, I'm looking at this and I'm coming to this conclusion. What was the vision for CMS when you look at what is going on? And I understand, we're designing the plane but we're flying it. But you know what? That's a problem. But I'm not saying we don't, that's not really a good analogy. So the thing is that what would you suggest as a recommendation, let's say, to somebody who's designing this process as we're going along and participating in it? Because as a physician, my desire is to fulfill the vision as well as not be, let's say, screwed over by the game. I don't have the ability to control the game. So that's why I had made a comment yesterday where I said you could be doing exactly the right thing and you still wouldn't be getting, the payments. And you were talking about the institution as sufficient to begin with. How can they participate and not be penalized? This is something that I'm concerned about, because it talks about the viability of this whole thing, because people are already talking about extending it, putting it into different, arenas, commercial and all that. But I'm just troubled by this, what you just presented.
Well, yeah, and I'm a finance guy, so the people that in my professional organizations, of course, want to make sure you're going to win the game. They don't want to go into something where you're not. So the sweet spot, obviously, is something where you can achieve the vision and also win the game. There are ways you could probably win the game and not achieve the vision, too. That's basically just playing with stuff. The only really good recommendation I could give would be, from a policy point of view, is people who are building these policies need to realize that the game can kill the vision. And they need, when you get into outpatient perspective, and when you get into oncology bundles and things like that, be really, really cognizant. The oncology bundles, the way we've looked at it, and I'm not the one who's working on it, but the oncology bundle is really hard to achieve the vision. You got to make sure that game is really pretty easy, or you're going to kill it right out of the gate. So that's really, the best thing that I can tell you. I think at NYU they had the opportunity to do some things that other people were not successful at. They've been successful with valves, or other people weren't successful with valves, and I just showed you how hard it was to be successful with valves. They've managed to do it anyway. Not everybody else could.
Thank you very much.